Right now, there are millions of Americans over 60 who wake up every single morning, walk to the kitchen counter, pick up their blood pressure pill, and swallow it without a second thought. They trust it. Their doctor prescribed it. It has a name they've learned to pronounce. It comes in a familiar bottle. And most of the time, it is doing exactly what it's supposed to do. But here's the part nobody told you at the pharmacy window. 3 of the most commonly prescribed blood pressure medications in the United States carry a hidden risk that builds silently inside your body, week after week, month after month, and you will feel absolutely nothing until the damage is already done. Your kidneys are being affected, and the most frightening part of this entire situation is not the medications themselves. It's that the warning signs are invisible. Until you've already lost function, you cannot get back. I'm Dr. Michael Hart, and before we go any further, I want to be clear about something important. This video is not here to frighten you away from your medication. Managing blood pressure is genuinely one of the most critical things a person over 60 can do for their long-term health. Uncontrolled hypertension does far more damage to your kidneys, your heart, and your brain than the medications we are about to discuss. What this video is here to do is give you the information that a 7-minute appointment almost never has time to cover. The research behind what I'm sharing today comes from peer-reviewed publications, including a landmark study in the British Medical Journal, a 2021 review published in the Journal of the American Geriatric Society, and data from a large-scale analysis in PLOS Medicine. These are not fringe findings. These are documented, replicated, clinically accepted risks that nephrologists, kidney specialists, have been aware of for years. The gap is not in the science. The gap is in the conversation between doctor and patient. That is exactly the gap I designed my guide to fill. The blood pressure protocol includes word-for-word doctor scripts you can bring to your very next appointment. Scripts that tell you precisely what to ask, what numbers to request, and what those numbers actually mean for your kidney health long-term. You'll find the link in the description below. If you want clear, research-backed health information built specifically for adults over 60, subscribe right now so you don't miss what we cover next. Let's get into it. By the time this video ends, you are going to know 3 things that most people on blood pressure medication have never been told. First, you'll know exactly which 3 categories of medication carry the strongest documented evidence for kidney damage in adults over 60. Not vague categories, specific drug names you may recognize immediately from your own medicine cabinet. Second, you'll understand why adults over 60 are disproportionately vulnerable to this damage compared to younger people, and why the standard risk assessments used in most clinical settings often fail to account for that gap. Third, and this is the part I want you to stay for, I'm going to give you 5 specific, actionable steps you can take starting before your next appointment. Not broad advice, not talk to your doctor. 5 concrete actions with specific language, specific tests to request by name, and specific alternatives to discuss. Because knowledge is the most powerful thing you can walk into that examination room carrying, and most people walk in carrying none of it. Here's what makes the situation so much more alarming than it initially appears. Kidney damage caused by medication does not hurt. There is no burning. There is no sharp pain. There is no alarm your body rings. By the time the majority of patients discover something is wrong, they have already permanently lost a significant portion of their kidney function. And unlike a broken bone, unlike an inflamed joint, kidney function that is gone does not return. The tubules, the microscopic filtering channels inside your kidneys, do not regenerate. The nephrons, the individual filtering units, once compromised, stay compromised. What you lose for the remainder of your life. That is not a reason to panic. It is a reason to be informed. Let's talk about exactly what we're dealing with. The first category is diuretics, and this is consistently the one that surprises people the most when they hear it, because diuretics are genuinely effective. They work. They lower blood pressure. They reduce fluid retention. Cardiologists and internists prescribe them millions of times every year, and for good reason. The names you're most likely to recognize: hydrochlorothiazide, chlorothalidone, furosemide. If the name of your blood pressure medication ends in IDE, or if your prescription says Lasix, there is a very high probability you are on a diuretic right now. Here is what the pharmacy almost never explains. Diuretics work by instructing your kidneys to push out excess sodium and water. That's the mechanism. That's how blood pressure comes down. But in order for your kidneys to perform that job safely and sustainably, they require adequate fluid volume to work with. Think of it this way. Imagine a factory that produces a high volume of output every day. Now imagine cutting the raw material supply to that factory by 30 or 40% while simultaneously increasing the production demand. The machines don't slow down. They strain. They overheat. They wear down faster than they were designed to. Your kidneys operate on exactly the same principle. Now layer in this statistic. And this one stopped me when I first read it in the clinical literature. Studies consistently show that up to 40% of adults over the age of 65 are chronically underhydrated. Not dehydrated in the dramatic sense, not dizzy, not disoriented, chronically, mildly underhydrated. Running a fluid deficit day, many older adults intentionally restrict their fluid intake to reduce bathroom trips, especially at night. That's an understandable quality of life decision. But when you combine that habitual mild dehydration with a medication that is actively pulling more fluid out of your system, the kidneys are being asked to work at maximum capacity without the resources to do it safely. The result, over months and years, is a condition called chronic tubular stress, a gradual deterioration of the filtering channels inside your kidneys that contributes directly to chronic kidney disease. And because kidney disease in its early stages produces zero noticeable symptoms, this process can unfold for 12, 18, even 24 months before a blood test catches it. Here's what I want you to do right now. Think about your blood pressure medication. If the name ends in ide, hydrochlorothiazide, or if you've been prescribed furosemide, comment below and tell me, did your prescribing doctor ever discuss how much water you need to drink while taking this medication? I genuinely want to know. Because in my experience reviewing patient histories, this conversation almost never happens in a standard appointment. There isn't time. There are too many other things to cover. And so the patient leaves the office with a prescription, a copay receipt, and no idea that their hydration habits are now clinically relevant to their kidney health. That is a gap that costs people function they cannot recover. The second category is ACE inhibitors, and this is the one that concerns me most, because the risk here is not about the medication being wrong. It's about the medication being right for blood pressure and simultaneously dangerous for a kidney condition that often produces no symptoms whatsoever. ACE inhibitors are among the most prescribed medications on the planet. Lisinopril, enalapril, ramipril. If you've been managing hypertension for more than a few years, there is a significant chance one of these names is familiar to you. They work by relaxing blood vessels, reducing the workload on the heart, and lowering systemic blood pressure. For the vast majority of patients, they are safe, effective, and well tolerated. But there is a specific anatomical situation in which ACE inhibitors shift from beneficial to actively harmful for kidney function. And that situation is called renal artery stenosis. Renal artery stenosis is a narrowing of the arteries that carry blood directly to the kidneys. It is more common in adults over 60. It often develops silently over years, caused by the same plaque buildup that affects arteries elsewhere in the body. It frequently causes no pain, no obvious symptoms, no signal that anything is wrong with the blood supply to your kidneys. Here is why this matters so much in the context of ACE inhibitors specifically. Your kidneys depend on a specific level of internal blood pressure within their own tiny internal vessels, in order to filter blood properly. ACE inhibitors lower that internal pressure. In kidneys fed by open, healthy arteries, that reduction is manageable. The kidneys adapt. Everything functions within normal parameters. But in kidneys fed by narrowed arteries, reducing internal blood pressure is like trying to push water through a hose that's already partially kinked. The flow drops. The filtration drops. The kidneys, already working against a compromised blood supply, are now also working against reduced internal pressure. A 2021 review, published in the Journal of the American Geriatric Society, documented something that should be part of every prescribing conversation for adults over 60. Seniors with undiagnosed renal artery stenosis placed on ACE inhibitors showed measurable, statistically significant drops in kidney function within the first 6 months of treatment. 6 months. In patients who felt completely fine. Let me tell you about Margaret. She was 68 years old when she came in with elevated blood pressure and mild ankle swelling. Her doctor, a good doctor, an experienced doctor, prescribed lisinopril. It was a reasonable, evidence-based decision. Her blood pressure improved. Her swelling resolved. She felt better than she had in months. But at her one-year checkup, her creatinine level, a key marker of kidney stress in the blood, had risen noticeably. Her physician ordered additional workup and discovered she had moderate renal artery stenosis that had never been detected. The narrowing had been there, quietly developing while she went about her life. The lisinopril had not caused the stenosis, but it had been silently stressing her narrowed kidney vessels for 12 consecutive months with no monitoring, no imaging, no early warning system in place. Her medication was adjusted. Her diet was modified. Her kidney function stabilized. She did not progress into advanced chronic kidney disease. But those 12 months of silent damage were irreversible. The function lost in that window did not come back. Margaret did everything right. She filled her prescription. She took it as directed. She showed up to her appointments. She experienced no pain, no warning, no sign that anything was wrong. And her kidneys were still being affected. So how do you know if you might have renal artery stenosis? The most reliable, non-invasive screening tool is a renal ultrasound with Doppler imaging, a test that checks blood flow to your kidneys directly in real time without radiation or invasive procedures. It is widely available, covered by most insurance with appropriate indication, and takes less than an hour. If you have been on an ACE inhibitor for more than 6 months and no one has ever monitored your kidney function through a creatinine and eGFR test in that time, that is something you need to bring up before your next appointment ends. Write it down, put it in your phone, bring it on paper if you need to, because that conversation will not happen on its own. Now here is where this gets complicated, in a way that I want you to understand clearly. Because the third item on this list is not technically a blood pressure medication at all. It's ibuprofen. It's naproxen. It's the pain reliever you've probably been using for years for your knee, your hip, your back, your arthritis. The one you pick up at the grocery store without a second thought, because it's always worked. NSAIDs, non-steroidal anti-inflammatory drugs, do something very specific inside your kidneys that has nothing to do with blood pressure and everything to do with what happens when they're combined with the medications we've already discussed. Here's the mechanism. Inside your kidneys, blood flow is regulated in part by a class of compounds called prostaglandins. Prostaglandins help keep the blood vessels within kidney tissue open and adequately supplied. When you take an NSAID, ibuprofen, naproxen, high-dose aspirin, you block prostaglandin production. The blood vessels inside your kidneys constrict. Blood flow through kidney tissue drops. Less waste is filtered per minute. In a young, healthy person with normal blood pressure, no diuretics, and no existing kidney vulnerability, this is a temporary, minor effect. The kidneys bounce back within hours of the medication clearing the system. But now let's reconsider the situation for a person over 60 who is already on a diuretic. They are already running with reduced fluid volume in their kidneys. Their kidneys are already working harder than normal to maintain filtration. Now add an ACE inhibitor. They are also experiencing reduced internal blood pressure within their kidney vessels. Filtration capacity is already lower than it would be in a younger, unmedicated person. Now add ibuprofen. The blood vessels inside their kidneys are now also constricting. Blood flow has dropped further. Filtration has dropped further. Each drug alone carries a manageable, documented risk. Together, the three create what nephrologists, kidney specialists, who see the consequences of this combination regularly, have formally named the triple whammy. A study published in the British Medical Journal found that the combination of an ACE inhibitor, a diuretic, and an NSAID doubled the risk of acute kidney injury in adult patients. Doubled. That is not a marginal increase. That is a 100% elevation in risk from medications that most people would never think twice about taking together. Research published in PLOS Medicine went further, finding that this 3-drug combination tripled the risk of hospital admission for acute kidney injury compared to patients taking none of these medications. And here is the part that I find most haunting about this entire pattern. Nobody is intentionally taking 3 kidney-damaging medications at the same time. A cardiologist prescribes lisinopril for blood pressure. An internist prescribes hydrochlorothiazide for fluid management. The patient picks up at the pharmacy because their knee has been bothering them. 3 separate decisions, 3 separate providers, or 2 providers and a self-care choice. No single person in that chain has the complete picture. No one is tracking the overlap, and the kidneys absorb the cumulative impact of all three simultaneously, in silence, over months. Let me tell you about Frank. Frank was 74 years old. He had been taking hydrochlorothiazide and lisinopril together for 6 years, a combination commonly prescribed together for blood pressure control, and he also used ibuprofen 3 or 4 times a week for chronic hip arthritis pain. He had been doing this for years. He felt fine. He was active. He had no reason to think anything was wrong. At a routine blood panel, ordered not because of any specific symptom but as part of a standard annual workup, his eGFR had dropped to 54. That number put him in the early stage of moderate chronic kidney disease. More concerning than the number itself was the trajectory. His previous readings showed a consistent downward trend over the prior 18 months. His physician switched his pain management from ibuprofen to acetaminophen. His hydration protocol was optimized with specific daily targets. His diuretic dose was carefully adjusted under close monitoring. Over the following 18 months, his eGFR stabilized at 58. It did not fully recover. It rarely does. But it stopped declining. Frank went from a trajectory that was quietly heading toward dialysis to maintaining stable, preserved kidney function for years afterward. The difference between Frank's outcome and a far worse one was not heroic medicine. It was a routine blood test that someone actually looked at. This brings me to something I want to spend real time on, because it is the single most actionable piece of information in this entire video. The only way to detect early kidney damage from blood pressure medications before you've lost a clinically significant portion of function is through blood tests, specifically 2 numbers. The first is creatinine. Creatinine is a waste product produced by normal muscle activity that your kidneys filter out of the blood continuously. When kidney function declines, creatinine builds up in the bloodstream. A rising creatinine level, even within what's labeled the normal range on standard lab panels, can signal early deterioration in kidney filtration capacity. The second, and more informative, is the eGFR, the estimated glomerular filtration rate. This is a calculated value derived from your creatinine level along with your age, sex, and body size that estimates what percentage of your kidney function is currently intact and operational. Here is what the numbers mean. An eGFR above 90 is considered normal kidney function. Between 60 and 89 indicates mild early decline. Worth watching, worth discussing, but not yet in disease territory. Below 60 indicates moderate chronic kidney disease. Below 30 is serious territory that requires urgent specialist involvement. Below 15 is kidney failure. Here's what makes this so clinically important in the context of medication monitoring. Kidney function naturally declines at roughly 1% per year after the age of 40, simply as a function of aging. A 70-year-old with an eGFR of 70 is not in the same physiological position as a 40-year-old with an eGFR of 70. The 70-year-old has less reserve, less margin for additional stress, less capacity to absorb the cumulative impact of a diuretic, an ACE inhibitor, and a weekly NSAID. What this means practically is that the standard thresholds on lab reports, the green normal flags, are not calibrated to the specific vulnerability of an older adult on multiple blood pressure medications. A number that looks reassuring on the page may represent early-stage decline in a 68-year-old that would be caught earlier and managed more aggressively if someone in the clinical chain were specifically looking for it. If you are over 60 and taking any blood pressure medication, you should be getting your eGFR and creatinine checked at minimum once every 12 months. Not because something is necessarily wrong, but because catching early changes gives you the time and the options to adjust course before permanent loss accumulates. If your doctor has not ordered a comprehensive metabolic panel, which includes creatinine, in the last 12 months, ask for one at your next visit. And if you want to know exactly how to ask, in the words that communicate clinical specificity without sounding confrontational, that exact language is in the blood pressure protocol linked in the description. Comment right now and tell me, when did your doctor last check your kidney function? Was it within the last year? 2 years ago? Longer than that? I want to understand what's actually happening out there in real clinical practice, because the data suggests these conversations are happening far less frequently than they should be. Before we get to the 5 steps, I need to address something directly. because I've seen this response in comments on previous videos, and I want to preempt it here. Some people will watch a video like this and think, my doctor knows about these medications. They wouldn't prescribe something dangerous together. This must be overstated. I understand that instinct. And I want to be clear, it is not about your doctor making a mistake. The triple whammy scenario, and the broader pattern of medication-related kidney stress in older adults, is a systemic problem rooted in how modern medical care is structured, not a reflection of individual physician incompetence. Here's why adults over 60 face a categorically different level of risk than younger patients taking the same medications. First, as I mentioned, kidney function declines naturally with age. By 60, many people have already lost 20 to 25% of their peak kidney function simply through the normal process of aging, with no disease, no injury, no prior medication exposure. That means they begin their blood pressure treatment with less reserve than a 40-year-old starting the same drug. Second, older adults are statistically more likely to be taking multiple medications simultaneously, a situation called polypharmacy. A 2022 analysis published in the Annals of Internal Medicine found that over 40% of adults over 65 in the United States are taking 5 or more prescription medications concurrently. Each additional medication increases the probability of pharmacological interactions. The triple whammy is one of the most well-documented examples of those interactions, but it is not the only one. Third, and this is the structural reality that I think deserves the most attention, the average primary care appointment in the United States lasts approximately 18 minutes. Within that window, a physician is expected to review your symptoms, update your medication list, address any acute concerns, complete required documentation, and order any relevant tests. The probability that a nuanced conversation about cumulative kidney risk from 3 separate drug classes happens within that 18-minute window, across patients who may be seeing multiple specialists, is very low. That is not a criticism. It is an honest description of the environment in which most older Americans receive their care, which is exactly why you need to walk into that appointment already knowing what to ask. Here is the part I've been building toward. The reason the triple whammy is so dangerous and so consistently undercaught is not because the science is unclear. It is because no single provider in the chain has the complete picture at the same time. Your cardiologist knows about the lisinopril. Your internist knows about the hydrochlorothiazide. Neither of them knows about the ibuprofen you picked up last Tuesday. And nobody in that equation has been specifically tasked with monitoring the cumulative effect on your kidneys. 3 ordinary decisions, 3 separate clinical relationships, 1 silent problem accumulating in a set of organs you cannot see, cannot feel, and will not miss until a significant portion of their capacity is already gone. That is the system failure hiding in plain sight. The damage is not dramatic. It doesn't announce itself. It doesn't keep you up at night with pain or discomfort. It simply accumulates. Quietly. Consistently. Till the day a number on a blood test makes someone stop and say, "This has been going on for a while." By then, the function is gone. This is not a story about dangerous medicine. It is a story about the gap between what the research clearly shows and what most patients are ever actually told. And it is a gap that is entirely closable, if you know which questions to ask. Here are the 5 steps you can take, starting right now. Step 1. At your very next appointment, ask specifically for a kidney function panel, a creatinine level, and an eGFR. If you haven't had this checked in the past 12 months while taking a diuretic or ACE inhibitor, write down these exact words. I'd like to check my creatinine and eGFR to make sure my blood pressure medications aren't placing undue stress on my kidneys. Your doctor will know exactly what to order. These tests are standard. They are typically covered by insurance. There is no reason not to have them if you are on long-term blood pressure therapy. Step 2. If you are regularly taking ibuprofen or naproxen alongside blood pressure medications, even occasionally for arthritis, back pain, or headaches, have a conversation with your doctor about alternatives before your next dose. Acetaminophen, sold under the brand name Tylenol, does not carry the same prostaglandin-blocking, kidney-constricting effect as NSAIDs, and is frequently a safer daily choice for older adults managing chronic pain alongside blood pressure therapy. Topical NSAIDs, diclofenac gel applied directly to the painful joint, are another option your doctor may consider. Topical absorption is local, with substantially lower systemic concentration in the bloodstream, meaning far less impact on kidney blood flow compared to oral ibuprofen.
Physical therapy modalities, including ultrasound therapy and targeted exercise protocols, have also shown meaningful efficacy for osteoarthritis pain management in multiple recent trials, offering relief without any pharmacological kidney burden. Ask your doctor which option is appropriate for your specific pain situation and your current medication profile. Step 3. If you are on a diuretic, daily hydration is not optional. It is protective. The general clinical guidance is a minimum of 6 to 8 glasses of water per day. But the right target for you specifically depends on your weight, your activity level, your climate, and how your kidneys are currently functioning. If you are intentionally restricting fluids to reduce nighttime bathroom trips, which is a genuinely common and understandable practice among older adults, please discuss this with your doctor. There are behavioral strategies, including fluid timing adjustments, that can meaningfully reduce nocturia while maintaining the hydration levels your kidneys require. Trading kidney health for sleep convenience is not a trade worth making silently. Step 4. If you have been on an ACE inhibitor for more than 1 year and no imaging of your kidney arteries has ever been performed, ask your doctor whether a renal Doppler ultrasound is appropriate for your situation. This is especially worth raising if your blood pressure has remained inconsistent despite medication compliance, or if any kidney function numbers have shifted on recent blood work. Renal artery stenosis is underdiagnosed in older adults precisely because it produces no symptoms until it is well advanced. Step 5. And this may be the single highest impact habit change available to you right now, today, before any appointment happens. Bring a complete medication list to every single doctor you see, every prescription, every over-the-counter medication, every supplement, every herbal product, vitamin D, fish oil, aspirin, the ibuprofen in the bathroom cabinet, all of it. The dangerous drug combinations we've discussed in this video almost universally develop because no single provider has the complete picture at one time. The cardiologist doesn't know about the ibuprofen. The internist doesn't know about the new supplement. The pharmacist fills the prescription without seeing the full interaction profile. One comprehensive list. Every appointment. Every provider. This one habit, simple, free, requiring no test and no prescription, has the potential to prevent serious, irreversible harm. Before you act on anything discussed in this video, one critical safety note. Do not stop any blood pressure medication without speaking to your prescribing physician first. Stopping a blood pressure medication abruptly can trigger dangerous blood pressure spikes, cardiac events, and stroke. Everything shared in this video is intended to inform a conversation with your doctor, not to replace one. Your physician is your clinical partner in navigating this. What you are building today is the knowledge to walk into that partnership better prepared. But the path forward is real and clear. Monitor your kidney function. Adjust medications with your physician's guidance. Protect your hydration. Bring the full picture to every appointment. You have options. You have leverage. You have the ability to change your trajectory before the damage accumulates to a point of no return, as long as you catch it early enough. Comment one of the following right now. Type, "Checking soon," if you are going to request your creatinine and eGFR at your next appointment. Type, "Already monitoring," if you are already getting regular kidney function panels done as part of your care. Type, "Sharing this," if someone in your life, a parent, a spouse, a sibling, a close friend over 60 on blood pressure medication, needs to watch this today. I read every single comment. I want to know where you are in this. And I want to make sure nobody watching this video leaves without knowing what to do next. If this kind of honest, evidence-based health information matters to you, the kind that covers what the research says and what the 18-minute appointment doesn't have time for, subscribe to this channel. We release a new video every week, built specifically for adults over 60. And next week, I'm going to walk you through 5 specific warning signs on a routine blood test that can predict kidney disease 3 to 5 years before symptoms ever appear. Numbers your lab report includes every time. Flags that most patients never know to look for, and that most physicians, in a standard appointment, never have time to explain. You'll want to watch that one. It may be the most practically useful video I've made for this audience. I'm Dr. Michael Hart. Take care of your kidneys. They have been quietly taking care of you your entire life, and they deserve the same in return.